everyone around the world. Nice to see you all. We're very excited to have today a great panel with 7 fantastic women from India. We're talking about India's private healthcare system and how COVID is impacting this situation in India. We are recording for 1.5 hours. We're also live streaming right now on YouTube. And I'm going to hand off to Dr. Madhupai, who is going to be moderating the full session. We're dividing it up in 2 sections. The first section where we're talking mostly about what is the impact of COVID on the situation and on the ground in India. What are the problems and challenges that we're seeing? And then we'll move into a section that is specifically looking into the solutions. And during this whole panel discussion, please feel free to ask any questions. We will take your questions in the end and do a Q&A that we get all the input from each of the panel members on your thoughts. Please use the poll. I will give you a quick feedback on our poll. The first question was, what do you feel in whatever country you are is the best kind of representation when we look at public or private mix? People are mostly saying that it should be mostly public or a mix between private and public. Only 6% of people think that it should be mostly private sector. So that was a nice start to kick us up in this debate. In India, private healthcare system should be better regulated. 94% agrees. And if we look at in India, payment for healthcare requires better insurance schemes so people pay less out of pocket. 78 people agree and 12% disagree, and we have 9% neutral. So this is a good start to kick off the debate, and with this I would like to hand over to Dr. Pai to take the introductions to all our wonderful panelists.
Thank you, Petra. Good evening, everyone in India and wherever you may be. It's an honor to moderate this panel with this incredible, talented set of people who've been writing, thinking, advocating, running around private hospitals, trying to get patients into care. So I've been thinking a lot about this issue of private healthcare in my own work on TB. So I'm a professor here at McGill University, director of the McGill International TB Center. I trained in a public hospital in India and I worked in a private hospital in India. I understand what it means to live and work in both settings. And the impact of COVID on private healthcare is specifically what we are focusing on, but it is not a question of public against private. I'm always uncomfortable with this dichotomized ways of presenting it. The reality is India is in a crisis right now. And India needs all hands on deck. Everybody needs to contribute to this massive need for healthcare in India for COVID and non-COVID. And the question is that being met right now? If not, what is it that we all should be thinking about and advocating for? So that's the big picture on why we are trying to do that. So India has just crossed 2 million cases of COVID. And we know patients are really, really desperately struggling for healthcare in both public and private sector. We're very concerned about what we're hearing about dramatic inflation and cost of care in the private sector, inability to get care for non-COVID conditions. It's a disaster in the making, and I think we need every single sector to pull their weight in this crisis and help India out. Now, this public versus private is a very old debate. Even when I was doing my medical training in the 80s and the 90s, this was a very polarizing type of a debate. And we can discuss how India ended up with 70 to 80% of healthcare happening in the private sector. We should talk about that. What made India so privatized in its healthcare? And why is the public health spending on health so low? Lower than most countries in the world. And in a crisis, did India use the lockdown effectively to dramatically improve public services? That's a question worth asking. And in a crisis, is it possible to suddenly regulate a private sector that India has failed to regulate for decades? I think this is what is really creating such a havoc, because in a crisis, it seems neither is possible. You cannot dramatically improve public health care overnight, even if you wanted to. And you cannot suddenly buy or extra capacity from private sector if there was no pre-existing regulation to make them do the right thing and still make sure they're compensated for their legitimate services. So that is the big picture, and we will get started. I can't wait to hear from all of you on what you've been working on and thinking about. So in the first segment, I suggest we focus more on what are the ground realities right now. In fact, I think this panel, we could legitimately ask, why is there not a private healthcare provider on the panel? Why is there not a private health hospital owner or CEO on the panel? And my answer to that question is, at this point, we are more interested in knowing what the citizen's perspective on this is. What are patients struggling with right now? What is it that is happening, the ground realities? And we obviously know private sector players are dramatically badly impacted in this pandemic, and they are also quite vulnerable. But I would love to focus us more on the citizen's perspective or on the ground realities of what is happening in India right now. So we have 7 panelists. First off, as introduction, Anu Bhuyan. Anu is currently at India Spend, where she does reporting on healthcare. And before that, I remember she worked at The Wire and Outlook Magazine, BBC News, and NPR. She trained at SOAS in University of London, and she's won the Bournemouth University's Journalist of Change Award for her report on extrajudicial killings in Manipur. Welcome, Anu. Inayat Kakkar is a qualitative researcher and a health advocate affiliated with the rights-based people's group, such as People's Health Movement, National Alliance for People's Movement, All India Drug Action Network, Common Health, and other groups. She holds degrees in law and social work and public health, and she has been very actively trying to help patients with COVID and non-COVID navigate healthcare in this very difficult crisis. Welcome, Inayat. Malini Aisola is a co-convener of All India Drug Action Network, ADAN, a public group, health group that has been working for many years. I remember ADAN even when I was a medical student in the 1980s, working on regulatory reforms to improve access to medicines, rational use of medicines, and regulation to rein in corrupt, unethical practices in the medical sector. And she has been, again, vocally advocating for better healthcare during this crisis, and high cost of treatment has been one area that she's been focusing on. Welcome, Malini. Rema Nagarajan is with the Times of India, doing a hell of a lot of reporting during this crisis. She was previously a Neiman Global Health Reporting Fellow at Harvard, and her work has been supported by the Pulitzer Center for Crisis Reporting. Welcome, Rema. Rukmini is a Chennai-based independent data journalist. She was formerly data editor of The Hindu and HuffPost India, and she's been doing, throughout this crisis, a nightly 5-minute podcast on COVID. I was engaged in one of her podcasts, and it's a fantastic service she's been doing, trying to cover the pandemic from so many different areas. Welcome, Rukmini. Sonali Ved is a physician by training, a graduate of the Harvard School of Public Health. She's consulted for various institutions such as WHO, UNICEF, and MSF, very passionate about quality of healthcare, and in endlessly helping patients get care in this crisis, not just patients, also migrants and many other vulnerable groups. Welcome, Sonali. And lastly, Vidya Krishnan is currently a freelance reporter who's been covering healthcare in India for more than 17 years. Previously was a health editor at The Hindu. She is the new this year's cohort of Harvard University's Neiman Foundation Fellow. And I'm excited about her book on tuberculosis that is supposed to come out next year. It's called The Phantom Plague. Thank you, Vidya. So absolutely incredible panel, and it's a real honor to talk to all of you. So I want to first kind of start off by an important perspective. Right now, forget public-private. If you're sick in India, COVID, non-COVID, heart disease, cancer, whatever, what is your likelihood of getting healthcare that is timely, that is affordable and manageable? Forget the which sector, forget where you are in India and you're struggling, because I'm hearing terrible things from my own family members. It seems like a absolute crisis in the making. So can somebody lay out the big picture with 2 million plus COVID cases and escalating every single day? What is healthcare access looking like for an average Indian right now? Who would like to take this? Yes, go ahead, Inayat. And then Rukmini. Yeah.
Okay, well, thank you first, Dr. Pai, for inviting me on this absolutely wonderful panel. I opted to take this question because we have been helping patients, at least in Delhi, so we have a fair amount of idea on what is happening. I think it really depends, of course, on where you are located in terms of your socioeconomic identity. I think if you're somebody who can afford healthcare, there are at least now private hospitals that have opened up non-COVID care services, but they're extremely costly. If you are somebody who comes from an economically weaker section, it is extremely difficult, particularly in non-COVID, health services, to get access because a lot of large public hospitals which people were reliant on have been converted into entirely COVID facilities. We are hearing, repeatedly that there are COVID beds which are going empty in these facilities, yet non-COVID services are not being resumed. And I think if you are somebody who is from a minority religious community, particularly the Muslim community, I think access to health services is very different considering the toll that the communalization has taken. We constantly hear from people from Muslim communities who don't want to go to public hospitals because there is this fear that has spread very rapidly in the community that public hospitals, are either discriminating against patients or the care that is being delivered for Muslim patients is not safe. And so this communalization we have seen has also led to people being pushed into private facilities because they feel that smaller clinics closer to their homes are safer.
Thank you, Inayat, for that. So from what I'm hearing from you is public sector and private sector are both not easy to access at this time, regardless of whether it's COVID or not. Rukmini, do you want to bring some database perspectives on this? Go ahead, please.
Yeah, I wish I had more, updated data, but there's a reason that that's not the case. So, as everyone working on this knows, it's hard to get representative, national, useful data on utilization of health services. So what I was able to find was really for very early in the lockdown, for the end of March, what the National Health Mission data was saying for utilization of services, primarily public services, and this was primarily in rural areas. And this, of course, showed just within the first few weeks of the lockdown, a big drop in immunizations, in access to, inpatient and outpatient care. And at that time, there was a bit of, sort of government messaging saying that people were out of choice, choosing not to go to hospitals because they were, afraid of infection. But you cannot delay. There's no reason why emergency services, for example, would show a decline. Cancer treatments should not be showing a decline. So it was clear that the lockdown and the lack of access to transport, as well as all of the disruptions in hospitals, which Inayat laid out, was playing out across the country. Two further things from this I want to say. The reason I have not been able to write any more about it since the end of March, which is now a largely irrelevant time, we don't have such strict restrictions anymore, is because within 5 days of me writing about this for Mint, the government took all of this data behind not a firewall or anything. It's what the NHM website now says is that it's under maintenance, and it's been under maintenance since 5 days after I wrote about it. So we have no idea what's happened in terms of utilization of any of this data in the last few. And I'll concede that there's administrative difficulties right now in updating data, but there's ways to be more honest about it. And what we can also imagine is happening is that the ripple effect of all of this. Now, every doctor you speak to will tell you about how there's been a huge decline in people accessing OPD services, all of their, regular, even dialysis, which is really frightening that there's been such a big decline in dialysis. Is that when things start opening up, everyone is going to reach their doctors in a far worse and deteriorated state of an ongoing chronic condition. And for private providers as well, apart from the fact of whether this was, how much of this was avoidable, what we should have done about it, thinking about going forward, I really think healthcare providers are going to have to reorient their practice in a way to deal with far sicker people coming to them for months and years ahead. So that's another aspect of private healthcare provision, even that private providers are going to have to keep an eye out for now.
Incredibly insightful, Rukmini. I mean, TB alone, and I know Vidya has been writing a lot about it. TB alone, we missed probably 300,000 plus TB patients who should have been seen and put on treatment just during the first 3, 4, 5 months of this particular year. And every one of them will presumably be sicker because they've been waiting and gone undiagnosed. So this is incredible. I mean, imagine dialysis is not, it's a life-saving procedure. If you don't get dialyzed on that day, you will become uremic and probably die by the end of the week. So I cannot imagine how all of this will not translate to excess mortality in India. And we all know, and we saw that wonderful report from Priyanka on how India is underreporting mortality across the board, COVID, non-COVID. So this is an additional area worth discussing. And as you also said, Rukmini, if everybody is going to present with sicker disease, presumably the cost of care for managing sicker disease will be much, much higher than something that you would manage when it's in the early stages. So what the economic impact of this is something that we will all have to wait and see. I think the next question I want to ask any of you who've been working on it and would like to take it, is there any evidence that private sector is contracted? So if you look at the number of GPs, okay, private family doctors, number of little polyclinics and nursing homes, which is like the bedrock of Indian private health sector, and then the small intermediate hospitals. Of course, anytime we talk about private hospitals in India, everybody thinks Apollo or Max, but they are only at the apex, right? There are hundreds of smaller facilities, there are private laboratories. Is there any evidence that that sector has shrunk in terms of number of facilities that are open, hours of operation, or hospitals getting locked because of COVID disease within the hospital? Is there any evidence that the sector itself has shrunk? Does anybody have any data on this? Vidya, you want to go?
Yeah, I'll take this one. I was briefly collecting data for, there was a court case in Delhi High Court for the longest time where private players who had taken leased land from the Delhi government and promised X amount of beds. There was someone who was keeping a daily update because the Delhi High Court had a monitoring committee and they needed a daily update of how many beds that are supposed to be for economically weaker sections are full at this point. And not only were the beds that were kept for EWS almost entirely empty. During the first lockdown, I think the stone that was set for it was, if you remember in March, there were 3 big hospitals in Mumbai that became a containment zone. And when things started in March, it snowballed such that Healthcare workers didn't have PPE kits. There was all sorts of chaos going on in the middle. And then just this directive to stop OPD and emergency services gave the private sector the license it needed to go further and then stop dialysis patients and cancer patients, are completely unrelated. And I feel like between these two directives that came that were not clear, and there was a lot of self-regulation because Max became a huge containment zone later. The nurses were infected, and I feel the big hospitals, they take, from what I reported, the big hospitals take in patients if you can pull strings and you can call, or you can beg, borrow, and get yourself in some way or the other. Then there are lots of things like, are you English speaking, and those kind of things factor into it. The mom and shop, like I'm in Goa here, and the smaller clinics, you just need to know the doctor for them to trust you, to allow you into the clinic, because there is so much stigma at this point. And all of it was unfortunately fanged by government policies. And it's such a toss of coin whether you get care for, like I had an asthma attack 10 days ago. And it's very difficult to get a doctor, even if you know that you have a history of some kind of, especially respiratory illnesses. But it's frankly frightening that everyone is at risk and there's just no safety net.
Anyone else has? Anu, go ahead.
Yeah, I can also just chime in here. I've been speaking to a couple of executives at big private hospitals, possibly for a story that I'll do at some point. I've been looking at, I've been doing a sort of series of reports for India Spend which we're calling the price of COVID. So looking at basically how the prices of healthcare are being distorted in this pandemic in various areas, not just for people with COVID, but also non-COVID illnesses. Various ways in which pricing is kind of creatively changing in this pandemic. So I've been speaking to some top executives at private hospitals, and yesterday I was speaking to somebody who said, this exactly what you were saying. When we talk about the private sector, we tend to talk in a binary, and when we talk about the private sector, we tend to think only of Max, Apollo, Fortis, Medanta, these kind of things. But the private sector is actually also very heterogeneous. It's not homogeneous at all. So nursing homes and all of these various other kind of models or structures also exist. And I think over the last couple of years, this private sector has had certain pains, or has claimed to have certain pains, whether it's the Clinical Establishments Act, which they have not been wanting to, get on board with, because it meant that they would have to come on board with certain standards, which they said were too expensive, not viable, etc. Or with Ayushman Bharat, which they said the remunerations were going to be too little. And now also with what's happening with COVID, governments, state governments have been capping the prices. So their claim definitely is that it's not viable. And I think, Madhu, as you said, that there isn't a private sector person on this panel today. But since I've been talking to a lot of these private sector guys, I'd actually like to put forward a lot of things that they've been saying, because when they talk to me, sometimes I'm not really sure the complete validity of what they're saying. So it'll be good actually to hear what other people have to say. So yesterday, the gentleman I was speaking to did tell me that, a big hospital like ours can probably absorb the shocks of what's happening during COVID, but a smaller hospital will not. And so a lot of smaller establishments are, at least this is what he says. I don't have the data. Your question was, do we have the data? I don't have the data, but this is what he says, that a lot of smaller establishments are wanting to, or going to have to shut shop, maybe for 6 months, maybe for 8 months, to ride out this pandemic, and then they'll open their shutters after that. But that they can't actually make it through this pandemic with, the fact that the government said, non-COVID patients cannot be coming in, entire hospitals or entire institutions have to be kept only for COVID patients. They just, there isn't, and also on top of that, now the price of COVID care has been capped in very arbitrary ways. That's the last story I did. It's fairly arbitrary and very varied. So with all of this, the private sector, I mean, right from your big hospitals to your smaller hospitals, their claim definitely is that they can't make it work. A number of the people I've spoken to often tell me, the public sector or civil society alleges that there's profiteering on their part. But if there is quote unquote profiteering, why doesn't it show up in their profit and loss statements to the extent that we kind of imagine, or us in the press, the way we write it up, or as activists and people in the advocacy community, the way that it is built up? The guys in the private sector feel that there isn't as much profiteering as we sort of make it out to seem. So yeah, to answer your question, I think there is a feeling that the private sector is hurting too much. Breach Candy Hospital, for example, said that they'll have to shut down if Maharashtra government really asks them to reserve as many beds. They're not, I mean, I think it's a situation of calling their bluff. And as of now, nobody really has shut shop. Everybody is complying with the new directives. But their claim definitely is that, if this pandemic is going to go on for 2 years, it's not viable for them to coast through 2 years with this kind of, economic model for them.
So Nali, you want to jump in here? Thank you.
We've been talking about the fact that private healthcare is a very mixed bag and a lot of variety. And just to paint that picture, I'd like to talk about a friend who works in the state of Uttar Pradesh, and he has a small clinic in a district of a population of 21 lakhs. And he was one of the few private doctors who was below 60 years in that area. And he ended up helping being roped in to help with the district COVID center, the quarantine centers, often being the only physician on call. And this was during the initial days. And he ended up spending a lot of money on PPE for his staff, on ration for migrant workers, etc. Right? So I just wanted to paint a picture which is different from the corporate image that we have. And, so I spoke to him today before this call, and I asked him, what's the state? He had to shut down his clinic for some days because of some infections. And he's like, we are open again. And things have, resumed as normal. So if a small private provider, he has maybe 20 beds with 2 ICU beds, can resume function in, it's not really rural, but it's the interiors, and can resume function, within, and we are right now in August. I do think that the big corporate hospital should be able to absorb the shock. And if they are not able to absorb the shock, then it's a question of value and efficiency. And are their systems really designed to be efficient, or is there a lot of wastefulness, which we talk about when we talk about quality of care? Yeah.
Thank you, Sonali. But I just want to kind of try and now segue into the whole issue of cost of private care right now, right? Now, we all knew, even before COVID, that India's private medical sector is capable of exploitative pricing, right? Unnecessary diagnostic tests, kickbacks, these are all so well known. I mean, they're ancient, right? And books written about these topics. So we know that the sector is capable of it, but has this pandemic made it substantially worse than, say, even last year is a question worth asking. Now, if the sector has actually shrunk, in other words, if there are fewer facilities open, or if there are fewer providers willing to stay open, or if some hospitals have been forced to shut down, and imagine if these folks are not bringing in revenue and they cannot pay the rent for wherever it is that they're practicing, or they have to lay off their nurses and their staff, and what that implies. And now if they have to get PPE kit to see every single patient, and there's a whole story some of you did on the cost of PPE and what that means. How is it that cost of care cannot go up, right? If they're seeing fewer clients because of PPE and infection control requirements, and on top of it, they have to now pay rent when they're not bringing in revenue, and all of the issues that we spoke about, it's inevitable that cost of care will go up everywhere in the world. It is not a question of just India. And it's not just a question of healthcare. Even our groceries will be more expensive because the supply chain is disrupted, fewer shops are open, all of the same kind of logical issues kick in. So if they are charging a lot, how much of it is a justified higher cost because of this immense disruption, and how much of it is just exploitation is a question worth asking. So Malini and Anu, both of you have also looked at this cost of care issue very carefully. I'd like both of you to weigh in at this stage. What are you seeing in terms of increase in cost of private sector care, COVID or non-COVID? Malini, you want to go?
Sure. So I think we have seen that, as you mentioned, the exploitation, the fleecing of patients has not really changed in any way. In some instances, we even have evidence that this is actually intensified during COVID. So you were mentioning some of the costs that hospitals often claim are additional burdens to them. But what we have found is in dealing with lots of patients is that often these costs are being offloaded directly onto the patient. So if you're talking about the cost of PPE, this currently constitutes one of the biggest contributions to the bill. In addition to that, there have been other kind of claims by the hospitals that they need to put up their doctors in 5-star hotels. But these are not costs that they can justifiably pass on to the patients. So what we have been arguing is that obviously every sector has taken a hit, and therefore we're willing to acknowledge that even the hospitals have undergone some sort of a loss of revenue. Certainly during the lockdown, every sector experienced that. But that is not a justification for unethical treatment of patients and to exploit them. Another thing that I just wanted to sort of point to in terms of changes of the private sector during the pandemic, which is very stark, is that not only has this exploitation been on a grand scale, so I was mentioning in some instances it's actually intensified, but there has also been another phenomenon, which is that basically the hospitals and their associations have organized in an unprecedented manner. So we are seeing various corporate hospital owners who are also leading the hospital associations, and I'll name some of these. So there is the Association of Healthcare Providers of India. There is another association called Nat Health. There's FICCI, of course, which we all know. And they have actually activated, not only are they doing this lobbying on the national level, but they have activated their various state chapters to obstruct and undermine the state's attempts to enlist the private sector on reasonable terms. So neither are they ready to come forward to actually address the pandemic, but they're actually obstructing any kind of attempts by the states which are desperate to have access to beds in private hospitals, particularly the advanced critical care beds. And they have been doing this, including through litigation. And therefore, they have actually played a role of blocking rather than coming up with constructive solutions. And the truth is that this organizing is happening to preserve an old way of doing business, which you were referring to even prior to the pandemic. And that old way is really a way of operating, with impunity, which is in a regulatory vacuum. And so what I would just like to mention here is that I heard Anu's comment earlier, and I do agree that, states have in a somewhat haphazard way implemented different kind of regulations, but I still consider this to be a watershed moment when various states have taken steps for the first time ever for regulating the cost of COVID treatment. And they have been supported very obviously by the central government. So even as flawed as those approaches might be, there is also a reason for that. And that is really because there is they are grappling with extremely strong lobbies within the states. And it has been extremely hard for some states to contend with these immense pressures. Because of course, as we know, private hospitals are completely unused to regulation. And I think the lesson in it for us is the need to bring a consistent regulatory framework through the means of, not emergency laws that are activated during an emergency situation, but through means of Clinical Establishments Acts, for example, post the pandemic.
Great points, Malini. And I fully agree. A crisis is the worst time to suddenly regulate a group that you have failed to regulate for decades, because it's simply not, nobody is in the right frame of mind and everybody is in a crisis mode, which might lead to some bad policies. We will talk a little bit more about this price capping and the variations across states and what some of it is rational, irrational, and what impact it can have. So Anu, a quick summary, if you wish, on your fantastic reports on cost of care. What is your big picture understanding of cost of private care right now, COVID and non-COVID?
Yeah, a couple of stories back, I tried to study some of the bills, and I realized actually that, again, going back to what we've already said, the private sector itself is so heterogeneous, and it's, I was trying to see what, let's say, ICU care would look like or cost like in X hospital, Y hospital, and Z hospital. And even the way in which billing is done, in some places, it's like, a patient is given a sort of consolidated, aggregated number per day, and in other places, it has a breakup. And that, I think, is very key in terms of, just how billing is done, like what is the software in which billing is done. because that determines transparency, and that determines accountability, that determines, let's say, litigation if you want to sue somebody and take them to court, because like, you know, with this PPE situation that Malini is talking about, and private hospitals are also saying that PPEs have taken up the cost of our healthcare so much, and that's definitely borne out from these bills as well, where PPEs are actually a huge chunk in some people's bills. PPEs are coming to like 60-70%. You know, the cost of the cost of them, you know, being given a bed, the cost of their consumables and their drugs and even doctor visits is much less than what PPEs are coming up to, which is kind of, you know, I mean, it's difficult to make sense of. But in some hospitals like Gangaram was charging people a flat rate of 10,000 rupees a day for a PPE. And, you know, this is COVID we're talking about. So if you are in a hospital, it's likely that your COVID situation is kind of serious. And if you are on a ventilator, then it's likely that you're going to need a ventilator for 10 days. And if you're going to be billed a flat rate of 10,000 rupees a day, so if you're in a hospital for 10 days, that's a lot of money. If you're in a hospital for 30 days, that's a lot of money that you're just paying on PPEs. But in other places, so Gangarams did not want to give a breakup. They were just charging an arbitrary and flat amount of 10,000 rupees, whereas other hospitals were, you know, 7,000 rupees. And then there was a charitable hospital in Bombay where there was a husband and wife who were both admitted, and, you know, I think the husband got a bill of about 3,500 rupees for a day for PPs, and his wife got something more, which means in that hospital, they're possibly billing patients on the number of PPs that were potentially used just on that one patient. Whereas in Gangarams, if there's a bay and there are 10 people in that bay, although if I'm a doctor or a healthcare provider and I enter that bay, I'm probably seeing 3 patients in that time when I'm there. And so, you know, ideally, the cost of that one PP that I'm wearing should ideally be split among all the people in that area, all the patients in that area. Gangaram is charging each patient, you know, individually for that one PP that particular healthcare provider is working. So basically, while a bill could socialize the cost of, let's say, a PP, which is such a big chunk of these bills, it's definitely a choice that private sector providers are making. So Gangarams is choosing to not split that cost of that one PP across all the patients, whereas some hospitals that are, the bills that I looked at, especially charitable hospitals, they are choosing to either charge a patient per what is actually used by them, or they're splitting it among the various patients who are also interacting with that healthcare provider. So it's not that it's impossible, but there's definitely a choice that private sector players can exercise. And I don't know, I mean, you know, others can probably speak to this better in the sense whether regulation is the solution, because these are, you know, very kind of minute nitty-gritties, and I don't know to what extent these can be regulated, whether it's too much of devil in the detail. But at the same time, when patients are coming out with bills of 16 lakhs and like just the PP alone, PP cost itself has been, you know, 10 lakhs out of that, or I mean, sorry, much less, but, you know, has been a big chunk of it. Something will need, some intervention is definitely required.
Dr. Pai, can I just come in here for a second?
Just 1 second, Nayat, and come to you, and then I'll go to Rema, who's been waiting. So Anu, some quick comments or questions for all of you. So there is no India-wide standard reporting format for a hospital bill. There is no such thing that this is how the bill should be broken up. There is no such India-wide requirement. So here again is a very clear potential ask that every single hospital in India has to adhere to certain transparency and breakup of billing. It seems absolutely critical. And you're right, Anu, without that, we are all guessing on what the hell happened and what the bill, why is the bill 8 lakhs and not 9 lakhs? Secondly, has anyone done a cost of goods analysis for PPE? So if you broke down all the components of PPE, the N95 mask, the face shield, whatever you want, and you actually costed out the raw materials, let's say they're manufactured in India, and then you assembled a kit, that one person PPE kit will cost, I don't know, 350 rupees or whatever. Will that help in then understanding whether 10,000 a day for a patient by hospital X is outlandish or whether it's reasonable for that? So who's done a cost of goods analysis for a PPE kit in India? Anyone? So we don't know what that means. We don't know the cost.
No, we do. I mean, we do. I think, yeah.
That's not true.
I think Rama's done some stories on this, yeah.
Yeah, Rama, please go ahead.
Yeah, so PPEs, it all depends on what you call PPE. So if you look at a bill, often what they call PPE could just be the coverall. And they would have separate ones for shoe cover, they would have separate things for goggles, for the N95 mask. So do they throw in N95 into what they call PPE? Do they not? I mean, it completely varies. And what is the basic cost of PPE? I mean, you ask any of the PPE manufacturers, they'll tell you it cannot be more than $600, or it maximum could be, $800. And it all depends on what all you're throwing into it. So none of the hospitals are actually breaking this up. And if they break it up, often it is, like I said, they will say PPE kit and they will charge you an amount. And then on top of that, they will also charge you separately for shoe cover. They will charge you for your goggles. They will charge you for head cover and all of those. So there is huge variability in what you define as PPE, and also, I mean, what all do you consider as part of a PPE kit? So all of these things have not been standardized by the government till today. And also, what is the standard for a PPE in terms of, what would you call a PPE? Would a raincoat be a PPE? Because it is, if you're saying that, blood permeability is the only test, then a plastic cover is the best thing to wear, because, blood won't go through. So would that constitute a PPE? So all of these questions have never been answered. We have asked, there have been no answers. I mean, manufacturers have been grappling with it. Now they are talking about actually exporting the PPE, and you still don't have standards for these. The other thing is, we are talking about no billing format, Madhu, but we don't even have laws which are enforced in terms of saying that people need to be given their bills. Because often patients have to fight really hard to get a proper bill from the hospital. Many of the smaller hospitals will give you a consolidated bill. Only if patient asks for it, and in many cases you have to fight for it, will you get a detailed itemized bill. Malini bear me out on this one, because she has seen the same thing, and she has helped a lot of patients fight to get their bills, detailed itemized bills. So the hospital stance has been pretty clear about this. What they say is, if a patient asks, we will give. Why should we give reams and reams of paper to the patient? This also, again, it's all on paper that, if a patient asks, we will give, because once you have paid the bill, getting anything out of that hospital is next to impossible. Though it, of course, on paper, you have the right to demand the bill.
And hospitals want you to give a daily deposit amount, correct? Every day you have to go and put down a certain amount of advance money.
Well, ideally, they would like you to put in the whole amount on the first day itself, and then they will keep deducting from that. When they have gone through that, then they will talk to you about depositing, making the next deposit. The other thing is, many patients have learned, and I think many of the people like Malini and Inayat have also learned that as you go along, you should be asking for a running bill, so that you know what you're going to be hit with at the end of it. That's again something patients are very reluctant to give, because they would rather give you a nasty surprise at the end. They don't want the patient wanting to leave the hospital because they find it, so they would like to move to a cheaper hospital. The other point is, you were talking about, I think many people spoke about the fact that 90% of our hospitals are small hospitals. That's true. In COVID, for example, if you look at it, in most the districts which are worst affected by COVID, they are mostly urban. And that's where all our healthcare is concentrated. There's hardly any healthcare facility outside of our urban Mofussil centers anyway, especially in terms of tertiary care. So if you look at that data, especially for places like Delhi, Bombay, all these places, maximum number of beds are concentrated in the larger hospital, and that they are the ones who actually treated a large number of patients. So while we would like smaller guys to have a voice, the smaller guys usually are also not at the table when you're taking policy decisions. If you look at any government committee, you will have a Trehan or you will have a Dr. Shetty, but these are all people who head large corporate hospitals, and you're expecting that the voice of the small hospital should be taken into account. They are the majority, they treat larger number of cases, but no, but they're never there at the table, right? And they also have never actually lobbied to be at the table. So CII will be interested only in the larger corporate chains, because they're only interested in where the investor money is coming. And unfortunately, the government also seems to buy into it, and they would let these guys set the terms for whatever policies framed in terms of regulating healthcare. So that becomes a huge problem, that you don't get to hear from a large section of healthcare providers who probably are catering to more number of people than these corporate hospitals. And yeah, I mean, about the fact that they faced a really bad situation in the time of COVID, and that they are running in losses. The question to ask is, what were your profits before COVID? if your profits were huge and you did not share those profits with the public, why are you expecting the public to foot your losses? Why should your profits be, yourself and your losses be socialized? I mean, this is a problem that not just India, but I mean, countries all over the world face. That when a company is making profits, they want to keep it for themselves. When they make losses, they want the entire society to step in and, all the bailouts that we hear about. It's the same thing that we hear in hospitals. And after all the fact that, because elective surgeries have been done away with, which are the big earners, and the fact that, without the elective surgery, they're not making that kind of money. Not a single COVID treatment bill, if you look at it, it's not as if they're not charging them for every little thing that they use. So, I mean, if you get a detailed itemized bill, I don't know what it is that they're talking about, that they're running at a loss. I mean, they are charging everything that they are doing for you. So, except that, all those elective surgeries from which they made money, they are not being able to do that anymore. So, the question is, that's a business model that you adopted. Your business model is not working now. Do I pay the price for the fact that your business model is not working? I mean, did you give me a discount because your business model was making more than enough profit before COVID? Those are questions which also need to be answered by the government as well as the hospital owners.
Thank you, Rama. Very, very insightful. Inayat, you want to add anything here?
Anu pointed out that costs that are being passed on to patients are being inflated in terms of PPE, and Malini pointed out that, these costs are being passed on to patients. But I think whether hospitals are even incurring some of the costs that they claim to are a bit suspect. So when you look at PPE, that is the one component where there is, a lot of overcharging and a lot of profiteering that's happening. But if you look at healthcare workers and their protests, and if you speak to healthcare workers, then that is the one component which they are continuously fighting with the management of these hospitals to get. So on one hand, patients are being overcharged for PPE, but on the other hand, we have healthcare workers on the streets, protesting, saying that we don't have PPE. Then hospitals claim that, they charge a large number of PPE because nurses and, staff members are working in 6-hour shifts. And because of that, PPE gets changed pretty often. But again, if you look at healthcare workers' protests, there are nurses who are saying that we are working for 12 hours continuously. In Pune, I think that was Aditya Birla Hospital, there were photographs that nurses were sending out to their nursing union leaders of bouncers being posted in their nurses' hostels to ensure that, that they do not protest. So are hospitals even incurring these costs is a big question mark, and I don't think we'll ever have answers to these questions, because hospitals never put out, they never put out their balance sheets in public. The only thing we hear is that we are incurring losses. The evidence that we get is in the form of reports which they have commissioned and they have paid for. So if you are incurring a loss, then why don't you put out these statements in the public domain, submit to an audit, let there be an audit. And as this doodh ka doodh, pani ka pani, let's see it, and then we can see what kind of support private hospitals need or don't need. And the second point that I want to make, there is something that needs to be said about the way large corporate hospitals appropriate issues that are being faced by smaller hospitals. So when you point out that corporate hospitals are overcharging, they will say that hospitals are being shut because we are making losses. And there was a report, a news report saying 25 private hospitals in Bangalore were forced to shut down or reduce their OPD timings because, they are making losses. But if you actually, look at the entire report, they're not private hospitals. They are nursing homes. They are smaller single doctor-run clinics. So these are issues that are being faced by smaller nursing homes, but they are being appropriated by larger corporate hospitals as an excuse to continue to profiteer and overcharge.
So one thing that is striking from everything you're saying is that we have very little trust or transparency, and that's why we're simply not able to really make sense of what is legitimate or what's not legitimate. And to be fair, the lack of trust is also in public health, right? How many people genuinely believe that they're going to get decent healthcare when they walk into a public facility? And if they had the trust, why would they still go and pay money and even go to an unqualified practitioner rather than go to a free public PHC around the corner, right? So that's a long-standing lack of trust in public health services, even if it's available and free, like we've seen in TB, right? I mean, TB care has been free for decades, and yet more than 50% of TB patients in India have chosen to go to a private sector, and people are not dumb. They're making thoughtful choices. They're going and willing to pay money, knowing fully well that they're going to an alternative practitioner or even an unqualified practitioner. They would rather do that rather than go to a public health services. So the lack of trust, I think, is in both sectors, which is why this makes it even worse, because an average Indian is now stuck between a rock and a hard place. Vidya, you've been writing a lot about the craziness around COVID testing, especially in the private health sector. So India as a whole, absolutely clearly is one of the rock bottom in terms of COVID tests being done, right? None of us have any confidence in the actual number of COVID tests done in India, or the rate of testing is completely disproportionate to the scale of the epidemic or the population size. So that's a given. And some of it is because the public sector was simply not invested in laboratories or was not ready to ramp up in a short period of time. While private labs, and there are thousands of private labs, we know that, it's been very dysfunctional. India could have really leveraged private labs and ramped up COVID testing way better than it has done so. But then we know private labs can overcharge, and that whole discussion starts all over again. So tell us, Vidya, what is your gut feeling on currently where COVID testing is vis-a-vis private sector in India?
It's available if you have money. It's convenient if you have money. You drive through, and if you can afford, like if I had to get 3 tests done for 4 members of the family, it will pinch me a little, but I would still be able to do it. But it's just not an option. It's they've not thought about poor people. They've not thought about, there are just sections of the population that's just not even accounted for in the policy that we have for testing. Frankly, I feel like I can't even comment on this well, because I don't even know what they are doing. Because you go, there are private labs. First of all, this policy was decided between ICMR and a group of private players who we later knew were invested in the diagnostic kits that were about to come in the market. How are we getting to this rate of 4,500 when there is costing studies that say that this test can be done for around 700 rupees? And there is such, you know, you said this thing about how there's no trust in the public sector also. And I would happily go out batting for the public sector at this point, because 70 years in, you can't, like, you know, it's this infinite loop of an argument that you don't invest in a sector and it's bad for ever and ever, and it being bad is the reason you go created this other sector, and because this sector is there, you don't put money in this sector. This is thing that is an infinite loop that forever, I feel where we are at is something that was going to happen to us sooner than later. I kept thinking when I was working on my book, it would be TB. Frankly, no one saw this pandemic coming, and what I feel, historically speaking, what India is doing exactly is what India has done in its years post-independent, where our founding fathers were like temples, or the industries are the temples of modern India. And nobody mentioned anything about health, hospitals and schools. And so up until 1983, we had no policy. We were in our 5th year or 6th 5-year plan. And our only way to think about these mass diseases were elimination campaigns. So we have leprosy, and what we have with COVID is like a version of that, where everything is directed towards COVID, and they're like, we will first stop this problem. But then we started this conversation with Rukmini talking about NHM being offline. There is equally bigger blind spot developing, which is IDSP surveillance reports for chikungunya, dengue. Just every disease has not been shared since like 12th week of this. So at this point in India, not only are the people medical hostages, there is just no idea what sorts of, what extent of outbreaks are spreading. Pregnant women are not able to deliver at hospitals. Every small thing that should have been taken care in the 6 months that has happened, because India is not a country like, you know, it's not Togoland, it's not Bangladesh. We have manufacturing capacity, we have doctors who have the skill, But we just do not have a government that is batting for us, and we are in a state of regulatory capture. There is no beating around the bush at this point. If Naresh Srihan, Devi Shetty and Kiran Majumdar Shaw are going to be setting self-regulating policies, this is how it would look. They would not factor in. I took a larger answer to it, but be it testing, be it you don't get reports on time. There was someone there was a report in Mumbai Mirror about a family of 11 that had joint family. Everyone had to be tested, and once you're in the system, you have to be tested thrice at least. If it's a family of 11 people, you're pauperized by the end of this just by testing. Then there will come the billing of the actual disease. Then there is a whole wild goose chase for things like remdesivir. This is the wild west that I've never seen anything like this. Complete governance void, and we keep talking about how charity and subsidies and activism will somehow be a replacement for governance. There is just no governance at this point. So
thank you, Vidya. Really depressing. All right, Malini, you've been waiting to jump in. Please go ahead.
I just wanted to add a little bit to what Vidya spoke about testing. And it's basically to say that the path labs have been one of the most irresponsible actors during the pandemic. They have lobbied, of course, as Vidya mentioned, to keep the price of testing quite high initially. And the latest development is that ICMR has now provided the green signal for the labs to also enter into antibody testing. However, they have done this without laying down any rules. So the current situation we're in is that we're basically in a jungle where labs are selling COVID tests in all combinations of bogus packages. And to add to this problem, we now have another actor, which is the online test kit aggregators. And these parties are completely unaccountable to anyone. And they are really managing to milk the pandemic to their benefit because they're misrepresenting themselves to the public as actual labs and not following any standards in terms of sample collection or reporting of results. And the latest, one of the things that has recently happened is a case has just been filed in the Delhi High Court by a Dr. Rohit Jain, asking for these test kit aggregators to be banned altogether or else to be brought under regulation. Just to wrap up, I'd like to say that transparency during the pandemic, there is actually a greater requirement for it, for not just sharing information with the public for increasing accountability, because after all, the first step in regulating is transparency, but also to ensure a better response to the health crisis. And the information regarding procurement of COVID-related products, including test kits, was absolutely essential to be provided in public domain. So for example, purchased orders placed by the various states and by ICMR, along with the rates at which these products were procured, their specifications. And the issue is that without this information, it is really a seller's market, and a lot of profiteering could have been prevented if this information was out in the public. We know now that RT-PCR test kits are currently less than 500 rupees. So there is still no justification for the current price caps. You know, I know they've gone down from 4,500 to many states going as low as 2,000, 2,500. But even this is way too high.
Thank you, Malin. I still don't understand that. We won't talk much about it, but I'm not getting the logic of antibody testing for patient care. Antibody testing worldwide are used for surveillance purposes, right? To know how widespread the epidemic is in a community. What is the individual clinical validity of an antibody test? What does it even tell you? That you're currently sick, or you had COVID 3 months ago, or do you have immunity, which we don't know how long lasting the immunity will be? I'm not understanding it. This reminds me of Wild West days of tuberculosis antibody testing, right? 10 years ago, the dominant test for TB in Indian private sector was antibody tests until finally it got banned. And now I can see the same Wild West of antibody testing in private laboratories for COVID, which I'm not even sure what the validity of it for any individual clinical management.
They have created uses for it.
Sorry?
They have created uses for it. It's not clinical, but if you land at airports to get into the state, you need an antigen test. And they are creating those kind of uses for it. And it's just a market, like she said, it's a seller's market. And they're just like in Goa, the resident welfare associations are asking for antibody tests.
It's like an immunity passport that you're free of infection or you already have immunized. It's all rubbish. There is really no validity for any of this kind of stuff, right? RT-PCR is what should be available for people with symptoms or suspected COVID. That should be affordable. But this whole antibody market is complete, irrational in my opinion, among many other things that are irrational in this pandemic. Okay, one quick show of hands. How many of you think that India's private medical health sector is capable of self-regulation? I'm laughing, okay.
I mean, if I was running a clinic, I would not be capable of self-regulation.
Okay, so that's a dead end, even as we speak about it, which also then begs the question if a sector is completely incapable of self-regulation, as indeed Big Pharma is, right? We know Big Pharma is completely incapable of self-regulation. Tobacco is incapable of self-regulation. It's many sectors that are incapable of self-regulation. And I think we should now use the last 30 minutes. I think we kind of get the big picture on what is really wrong. And we know the public sector is overwhelmed. It has always been overwhelmed and underfunded, and now in a COVID crisis. Is it correct to say that in this crisis, people are starting to go to public sector for COVID? Is that, in other words, do people have confidence that public is the place to go if you had COVID? Or is that still not the case? Sonali?
So I think the example of our Home Minister pretty much represents the ideal mix of public and private. So go to a private hospital and invite doctors from the public sector to come and see you. There's still a lot of trust in government doctors per se. You know, my mother wants a knee surgery happening at a government hospital. She's still not sure she wants to go to a private hospital. But I'd like to go back to something that I think Malini said, but I might be mistaken, about how the big private corporate entities are cooperating during this crisis. And that is really worrisome, because we have seen what lobbying does in other countries. If we take the example of the US, the gun lobby, the health insurance lobby, it will completely stifle any movement towards a public health, towards ramping up public health care or increasing investment in public health care. So that's a very worrying trend. And yeah, so I'll leave it at that. Yep.
Okay, so I'm going to now ask each of you to give us one serious, concrete suggestion on how to fix this disastrous situation we are in, right? We are in a very bad situation. Neither the public is optimal, nor the private is optimal, and people are really caught between terrible options in this crisis, and even before this crisis, to be honest. So if you could wave a magic wand and make one thing happen, right? One thing that you passionately believe will be a path forward for India's healthcare, what would be? So let's start with you, Rama. What would be your wish list that if you could really fix something, what would you fix?
I think the first thing is for the government to acknowledge that 90% of your population actually earns less than 20,000 bucks a month. So, I mean, your so-called regulated rates are unaffordable for 90% of your population. So then you need to be more realistic, and you need to see if you can help in paying those bills. And if you have to pay the bills, then you also need to audit the bills. So the most realistic expectation I have, because we can't wish away the private sector right now in the middle of this crisis, but we can definitely ask for an audit of all the private hospitals, a random sampling of their billing, and forensic auditing of their billing. That's the least that the government can do at this time.
Thank you, Rama. Very concrete. Rukmini, what would you like to change or suggest?
So I'm going to sort of try and not repeat things that I know others will say. So it's slightly on a tangent, which is that for a constructive approach forward for everyone, not just the government, I would want everyone to have a more realistic idea of where people seek their care from, so that people, like, to crudely, I'd say largely everybody on this panel has sort of similar politics, to use the word not as but to use it in terms of beliefs, and sometimes that shutters us from properly understanding the role that the private sector plays in people's lives, as well as the huge failings of the public sector. So this, for example, the biggest horror story that has stayed in my mind of a hospital, of course, there's all the pauperization that private hospitals are doing in terms of care. There's a horrific story from Jala, which is in Maharashtra. Just about, I don't want to, scar everyone with the details of what a family went through, and the extent of lack of most basic care that was demonstrated in this highly neglected government hospital in Jalgaon. So I wouldn't want state capture by private players, but I also would not want us to close our eyes. All of the what we want for the future, why this happened now, that's one conversation. But the quality of care that we are sentencing people to endure is also not something that we can take lightly.
Thank you. And I hear you. Quality of care is a big issue. So if we say, let everybody go to public, and if they get poor quality care, then it's a self-defeating exercise, right? So you cannot just say public without actually improving quality of care. In fact, I want to ask Sonali, Sonali, you're very passionate about quality of care, and I've been doing a lot of work in that area for TB. Is there any evidence that private or public is doing better in terms of quality of COVID care, for example?
So not aware of COVID per se, but you yourself have done work on TB, and I've read some of that. And Jishnu Das has done some work on this using standardized patients. And it's a mixed bag. Overall, everybody's suffering, whether they go for private or for public. So the assumption of, and quality needs to be thought of, clinical quality and service quality. And I would also add a third dimension, which is, what is the humanity that the patient experiences, right? So, of course, in the private sector, you would probably have slightly better service quality. Again, but where does it figure on the humanity scale, right? If I go to a ICU in, say, Medanta or Fortis or Apollo, let's talk about pre-COVID times. How much visiting time would a relative have to meet me? Versus if I'm admitted at Safdarjung, they need my relative by my side, right? So I have an attendant by my side 24/7. What is more humane, even though it is out of necessity? So, and when we talk about clinical quality, the results are mixed. There is, Jishnu Das says, there is more provider effort in the private sector. It's not a very clear picture. You are not guaranteed better quality of care in the private sector. And that's where the other point comes about the wish list, right? I have been desperately looking for a decision on where to take my mother for knee replacement surgery. I've delayed it by 2 years. I did not know a pandemic was going to delay it further, because I don't know where to take her, because there is no outcome data which is publicly available. So in addition to bills, I would like to see data on clinical outcomes in hospital infection rates, right? Why is that so difficult? That is available internally. I remember being in an office in Medanta and they said they have this information. So, but it's not publicly available. I'm only aware of one hospital in Delhi, Sitaram Bhartiya, which publicly displays its cesarean section rates. I'm not aware of any other hospital displaying their outcome data. And same goes for government hospitals too. Why not, right? So, yeah.
So would your wish list be some kind of a rating system for public or private hospitals in terms of quality, outcome data, service delivery indicators, some kind of a dashboard which tells you, do I go here or do I go there?
I'm not sure about a rating system. I'm not sure about accreditation systems also. I think accreditation systems can be gamed. They're expensive, especially international accreditations. They add to the cost, and they don't necessarily ensure quality. Again, the evidence on accreditation ensuring quality is again a mixed bag. You know, even in terms of, let's look at fire safety, right? Look at what is happening. There was a fire last year in Ames. I was there in the building that morning, and that evening there was a fire. And a few days ago, there was a fire in a COVID hospital. So one is private, one is public. You know, where is the, how good have our accreditation systems been in terms of controlling these things? So I'm wary in terms of external benchmarks. I think it has to be a self, and I may be contradicting myself now because I said they're not capable of self-regulation, but I do think some level of peer pressure would work. And especially in terms of the more lucrative things, surgeries, etc. And there has to be a move towards transparency in outcomes and in cost both.
Thank you, Sonali. Inayat, what would be your wish list, on top of your wish list?
Sorry, I coughed. Are you asking me?
Yeah.
Okay.
What would you like to fix?
Okay, so since I represent, you know, civil society groups, and this may be slightly provocative, and I'm sure a lot of my colleagues are also watching this, but I think if I could wish something, it would be, you know, if civil society groups and patient groups could be better organized as far as dealing with the private health sector is concerned. You know, right now we have, you know, HIV patients fighting one fight, and we have COVID patients fighting one fight, and then there are non-COVID patients who are, you know, who have their own set of issues. And I think while broadly civil society positions are clear that we oppose privatization, as Rama said, we can't just wish the private sector away. So I think and as Rukmini was saying, that, you know, it is an aspiration and a demand that people have, that they do want care in the private sector. So I think, you know, I think we need to be better organized to reckon with some of these things and to develop more nuanced positions. Because right now, while healthcare has certainly become a political issue, you know, Ayushman Bharat was so center stage during the last elections, the right to health has still not come on as a political agenda. So I think that's, if that's one thing that we could bring on board, then that would be my wish list. Yeah.
So you would like to see right to health and that become a critical election issue. So I remember watching another webinar, and Rama was speaking in this, where she said something like, it's because the middle class are getting hit hard in this crisis, that for the first time this is even a discussion. Otherwise the rich people never really cared about healthcare, and that's why it's not an election issue. So this is obviously a fundamental issue. How many of you think that India should invest more in public healthcare? Everyone. All right, and at least 2.5% of the GDP, or should it be even higher?
What's I don't know where that number, where that expectation.
2012, our target was 3%. How can the target go down from 3% to 2.1% when we reach 2020? That's ridiculous.
Absolutely. I mean, right now we are willing to even accept the lowest bar in terms of increase in public spending. And yeah.
But I think we also need to talk about where this public spending is directed, right? I mean, recently, I think maybe to somebody in the Niti Aayog who said that we should increase health spending, and then, you know, later somebody else said that we need to increase, you know, the PPP model. So if we're going to increase public spending and then spend it on the private health sector, then that might not lead us to the goal that we really want to move towards.
Fair point. Malini, what is your top on your wish list? If you could wave a magic wand.
Sure. So I'm from the All India Drug Action Network. So I think I have to talk about the pharmaceutical industry. So basically, I'm going to talk about the industry's behavior during COVID. And so we know that in the absence of any established treatments for COVID, the pharma industry has really grabbed onto any opportunity to launch or produce experimental treatments. And this in itself is not wrong or bad, but we have to understand the backdrop against which this is happening, where health products are being approved on the basis of waivers and to producing evidence and accelerated processes. And this is, you know, whether it's drugs, diagnostics, or vaccines, and enabled by literally the lack of transparency of the drug regulator. The pharma industry has been both cutting corners and not producing adequate evidence, and also, even in the absence of that evidence, heavily promoting their experimental treatments. And the price has purposely been kept very high in order to monetize from the pandemic and the anxiety of the public. And as a result, we are seeing heavy off-label use of these products as well, often in violation of treatment protocols. So I guess what and that brings me back to the role of the regulator. So CDSCO has undoubtedly been a weak link during the pandemic, not just the CDSCO, I wouldn't single out just that agency, but broadly, because it has generally been a challenge to get information regarding the basis of the approvals of COVID diagnostics, for example, and other therapies. So we'd like for this to change, because we, as the pandemic progresses, we're hoping that, there will be, there's already been a lot of, people have already spent lots of money on treatments that we're still not sure, we're still not sure about the utility. And surely this will continue. And this is what we're really looking towards, right? We're looking towards some sort of vaccine being developed, or some of these therapies. Hopefully we find more evidence that they will work.
Thank you, Malini. And it's not just India, the insanity around experimental medicines and therapies. And look at this whole hydroxychloroquine fiasco. I mean, right from US, Brazil, it's just absolute madness on how all rational scientific standards have been thrown out of the window. People are just rushing and promoting all sorts of rubbish that is untested. So I can totally see your point that India is becoming a Wild West for all sorts of untested products flooding the market, and then also it being priced that is disproportionate to the need. Anu, what is on top of your wish list? What would you like to change?
I think as a journalist, and the other journalists here will know this, we've been reporting on the price of healthcare for a really long time. 2017 was a particularly stark year, where Medanta, Fortis, they were in the news every other day for their high prices. So I think, as somebody else said, and as we're saying all around the world, really, it's not that the pandemic has broken things. Things were already broken, and a pandemic is not a good time to be fixing things. But now we're in this, and this is going to pass. So may we kindly fix things when this is over. So I think a lot of the themes that have been coming out in this are coming together very well for me, because it's also things that I've been thinking about for a while. So I tweeted some time ago, and I said, how is it that when Max Hospital puts out their rate card on Twitter, this was before the state government started capping prices, they said that it would cost a minimum of about 72,000 rupees a day if you need to be in the ICU with the ventilator. And the Delhi government and the UP government have brought that down to a maximum of 18,000 rupees. So Max Hospital, if they were allowed to do what they wanted to charge at least 72,000 rupees a day, plus. And then the government has said it needs to be only 18,000 rupees. Now, the thing is, the reason why this entire subject is so kind of difficult to wrap your head around, and as you said, we neither trust the private sector nor we trust the public sector, is because if you do manage to get into a government hospital, you'll be treated by the best doctors, you'll be paying zero, but you're not going to have a great experience, either to access it or while you're in that facility, you're not going to have a great experience. But when you go to a Max, you'll be treated very well. You'll probably be given cut fruits wrapped in cellophane, which is how people are served food there, but you'll have to pay 72,000 rupees a day. So the thing is, I think why this situation is so difficult to understand is because Max wants us to believe that 72,000 rupees a day is really just a little bit above what their own cost is, and that's what they're pricing it at to us. Whereas the public sector is willing to offer us ICU with ventilator for 0 rupees. So the difference cannot be this stark, that your public sector is absorbing 72,000 rupees a day, not really, a little bit less. Whereas Max Hospital is saying 72,000 rupees is like we're doing our best and we're charging you at 72,000 rupees. So I think all of this really comes down to, so when I put this question, how is it that the public sector absorbs all of this and the private sector says that we're barely able to manage costs? When I put this to some of these, guys at private sector hospitals, they essentially came back to me with exactly what you're talking about here, which is quality of care. Now, they're able to make that assertion that we're providing a quality of care, but they don't have the data. And as a journalist, I don't have the data to counter it either. So it's a bit ridiculous that we've been clunking along for so many decades. And, I think as Sonali said, if the private sector is reluctant to put out data on their quality of care, what's stopping public sector hospitals from saying, from beating their own chest and saying, look how well we are doing on our quality of care. You know, you're paying nothing and this is how well we're doing. So let them boast, let them brag about it. And, you know, then if need be, and if they can somehow manage to get the private sector to also put that out. But right now, the lack of data means that the private sector gets to make this assertion that the quality of care is better here, and they get to get away with it. It might actually be true, but neither a patient nor civil society nor myself as a journalist has any way to challenge that. And the government has no way to then regulate or make a policy prescription, because the private sector is going to continue to always assert that it's better there. And we are supposed to just believe that if you go to the public sector, you know, that we must pay this kind of premium, even if it's 72,000 rupees a day, because you're going to get better, you're going to have a better outcome over there, and there's going to be better quality of care there. So I would like more data, more transparency, more auditing, you know, a lot of the themes that everybody's been talking about.
Thank you, Anu. Vidya, what would you like to change?
You should never give me magic wands, because a lot will change. If I had a magic wand solution, I feel instead of going into specifics of this drug or that hospital, this system is rotten. It's rotten in the private sector. You get overtreated if you're insured. It is really rotten. If you're poor, there's no dignity. It needs to go. It needs to be burnt down and built from scratch. And the only good idea I have heard, in fact, came from a doctor. I think it was Dr. Kalantari or Dr. Yogesh Jain, where on Twitter they asked for one nation, one health scheme. It's the most lucid idea I have heard. We have to stop this medical apartheid where the medicine, science changes depending on how much money is in your pocket. There are standard operating protocols, and whether you're private sector or public, like in every other country that they manage to do, whether you're mom and pop clinic or a big one, if you have malaria, there are same 5 things that you're supposed to do. And that only comes where we stop this medical apartheid. It is deeply rooted in this very casteist segregation. And I would, if I had I feel the only solution, in fact, even robust European nations with better health systems are looking at nationalizing healthcare. And I feel it's time to have that conversation in India, especially if you benefited from taxpayer largesse. Which Medanta has, which every big hospital has. They don't pay electricity bills, they don't pay water bills, they don't pay land. And for next to nothing market value, they set up these facilities and they milk patients, and this cannot go on any longer. I feel that if the activist community and the patient communities, like I think Inayat was saying this, unless we have one big conversation, it can't be access to cancer drugs or access to this one thing or that audit. It has to be one big conversation. Everyone gets the same quality of care. You're rich, you're poor, it doesn't matter. This will only be fixed if the rich people feel just as scared of walking into a hospital as a poor woman goes before she's taken in. There is just, so that's how I will use my magic wand.
Thank you. Lots of wonderful suggestions to think about. A few questions before we close. So one question is, can any of you comment about access to healthcare right now in rural parts of India? What on earth is happening in rural India? Are informal providers still the place to go because there is no formal sector? What happens when COVID hits rural India hard? What's going to happen?
I can take this, again, no one can say anything with great certainty, but I know because I was following a few TB patients in Samastipur. And before the first lockdown, there were a few patients who had been tested and were supposed to be started on DOTS therapy when the lockdown happened. And the patient just bled from the mouth and died. And that's just like one case. But then since March, the escalating cost of healthcare has pushed people towards these Ayush therapies, but Ayush therapies by itself is a problematic area, but there's so much state-sponsored mumbo-jumbo, homeopathy, and drink Patanjali products. So what's happening in rural areas is definitely not, there is no modern medicine reaching patients in rural and semi-urban areas. That much I can say with a certain degree of confidence, because I do know patients who are flying into Delhi or Mumbai for urgent surgeries.
So this will be a pretty desperate situation if the pandemic escalates in rural India. We may not even know there's a pandemic there because nobody's even testing much in rural areas. Another question, maybe Rukmini, you can take a shot at it, even if we don't have updated data. Is there any data that insurance is saving people who have to deal with crazy bills at this point, either through PMJY or through private insurance? Are people really getting reimbursed for this exorbitant healthcare costs?
So I can't say what's happening with private healthcare, but from Ayushman Bharat, there's been very little data made public, and the early data was actually, sort of used to try and make the point that people were that there was no increase in respiratory disease or other related illnesses, to try and make the point that there wasn't undiagnosed COVID. That was the only sort of purpose that the Ayushman Bharat data was put to. Whether it's played a important role in treating patients and reimbursing their costs, I have tried and not been able to get any good data on it.
Rima, you want to say something about insurance?
I think Malini should answer her experience with helping patients who have insurance.
Malini, go ahead.
So I think that in terms of the public schemes like Ayushman Bharat, there has been very little utilization of the insurance to cover treatment and for COVID. And this is some figures have been occasionally shared by the NHA, and so we know that it is extremely low. We also know that a lot of the big hospitals that are providing COVID treatment are not empaneled under these schemes. Then when we're talking about private insurance, we have come across many cases. So the assumption is that people who are covered through a private insurance are sufficiently, they have sufficient financial protection. And this is also turning out to be false. There was some data released by the GIC. I think a few stories of this were done. And there also it was showing that even people who had some insurance cover were still having to shell out a lot of money for costs that the insurance companies were refusing to cover. And that was, we're talking about very, very high amounts. So in 70, 80 or maybe more than a lakh. 70,000 or more than a lakh. And then recently, I think Rama was, she's aware that we're currently, assisting some families that have run out of their insurance cover. So there are families where, there are many middle-class families that do have private health insurance, but the coverage is really not that high. And it could also be covering 2 or 3 people in the family. And so when one of them falls ill, or God forbid, more than one person needs COVID treatment, then that gets depleted extremely fast. And then there is also another complication. So many states, as you know, have been trying to regulate the rates for COVID treatment in private hospitals. But in many of the states, either through the policy or unilaterally as a policy decision by private hospitals, they have decided to exclude insured patients from these rates, which means that they get charged at very high prices, very high rates, and they run out of insurance, and then they're stuck with very fat bills.
Thank you, Malini. So we're almost.
I can just quickly add like one small point to what Malini said. One of the patients who we've been helping, he has also told us that, and he is on a private insurance, and he also told us that the private hospital told him that if you are going to pay with cash, if you're going to pay out of pocket, then the rates will be lesser versus compared to if you are an insurance patient. So there seems to be, a general consensus that if you're an insurance patient, you're up for being milked. And yeah.
How many of you, quick show of hands, how many of you think, one question that has popped up in the chat box is, should India just temporarily take over private hospitals until this crisis is over and nationalize and run it? How many of you think that that's a viable solution? Only Vidya. Okay, so that looks difficult. Okay, one more quick show of hands. How many of you think that this price capping that is currently happening, even if it's haphazard and it's going variation from state to state, that some kind of price control right now is at least helping in this crisis? Price controls are working. Okay. But would you like to see it uniformly done across the board nationally rather than Delhi doing it, Mumbai doing it, and so on and so forth? Would that make sense? A more national approach to and would you like to see that done for COVID?
Don't want too much power with the union government over healthcare.
Say it again, Sonali.
I would not like to see the union government taking over healthcare more and more. I would
leave it to
more
the
decentralized decision making. Yeah.
I would also add that it is a more complex answer.
Okay.
Yeah, I think while we need some sort of a like a uniform standard, but of course, depending on the issues and the context of the state, there will be differences. But I think what I would like to see is
private sector care for COVID. There is still this cost of non-COVID that is going to mount, right? So we cannot have just this price capping for just this, just that, because patient is the same patient. The same patient might have cancer after this. Then what happens, right? So it needs to be a lot more comprehensive. All right, so we are out of time. We could have gone on for another 2 hours easily. We have lots of questions. What we will do is Petra will send them out to all of you and you can take a stab at answering whichever you feel comfortable in doing so. We will collate that and we will post it on our website along with the recording of a video. This is not an easy session for me to summarize, but I am sad. I'm very sad and depressed. And it's distressing to see how Indians are totally polarized and caught between such terrible options in this crisis, both for COVID and for non-COVID conditions. And it seems, I think Anu said it the best, the system was broken well before COVID. Let's be honest. India's healthcare has been in dire straits for decades. And those of us who could afford private care have kind of neglected it or ignored it. Because it didn't pinch us hard directly. We could always go and find someone we knew, pull strings, pay money and get our way through it. But now it's hitting everybody and everyone. And now we are waking up and realizing how broken our healthcare system is and what we need to do about it. Even if some of these emergency measures are somehow will carry us through this crisis, it still leaves this big question unanswered, because next year India's healthcare needs will be double, quadruple of this year for all the reasons we've just spoken about. So you cannot just think from crisis to crisis. There has to be a long-standing solution for India's healthcare, and that involves dramatic increase in investments in public health. It cannot just be left to this ridiculous 1.5% GDP or whatever lowball amount that the government has been spending for years. And Indian public health not only needs additional money, they also, like you said, need to do better job of quality of care and to win people back into the public system. And private sector undoubtedly needs to be better regulated. This is not a sector that is capable of self-regulation. And this is not regulation is not a bad word. Regulation is critical. I mean, doctors need to be regulated, pilots need to be regulated in every field. There has to be certain regulations and norms that have to be adhered. It cannot be the Wild West. And a private sector that doesn't believe in regulation, it's in the long run doomed, because they will suffer in the end. They have to find a way to say, yes, there is a crisis, and yes, we are a part of the country and we need to contribute to this. And here is how we're going to come to the table and make this happen. I think this all hands on deck approach has to be critical in this crisis. I cannot see any one sector having enough weight or the ability to take India through this crisis. And so I congratulate all of you for your incredible work and your activism and your writing. I hope you will continue to write about this. I mean, even this webinar is like 10 stories put together. So find ways to bring this to the public attention. And like Rama said in one of our webinars, the day health becomes an election issue in India would be a new day for the country, right? Because all these years we've simply sat on this and allowed this by benign neglect to become as bad as it is now. So in a crisis, everything looks dramatic, but these situations were not new. Even before COVID, everything we spoke about was still true. COVID has just made this much worse. Petra, is there anything you want to say before we close?
Sorry, no, nothing specific. Thank you so much to everyone. I just wanted to thank all the participants for their incredible input. We have 73 comments, and yes, we will follow up. We will not let all your comments and questions just go fly in the ether. Thanks to India Spend and to McGill TB Center for helping us co-organize this, this session. And everything will be available on our site and on YouTube, and we will definitely also be available on Twitter. Do look out for a next webinar that is coming up. But in the meantime, I just wanted to thank everyone.
And thanks all of you. Please stay safe. I know this is a very hard time for everybody in India. So please stay safe and continue your amazing work.